Well, thank you very much for asking me to come here and talk about the kinds of stuff that we do. My background is chemical engineering. I did an undergraduate degree here at McMaster in chemical engineering, and then I went on to do my PhD more in biomedical engineering at U of T. So I worked on wound healing in the eye during my PhD. I did postdoctoral work again here at McMaster looking at biomaterials. And after a relatively short academic stint at the University of Ottawa, I came back here as a professor. And what I've done in my research is I've put together my interest in the eye that I developed through my PhD and my interest in materials, and have developed a research program around using materials to solve eye-related problems. And Fran's actually one of my PhD students, so she's going to present some results from the group. I'm going to kind of present some overview of why would an engineer ever wanted to do anything related to medicine anyway, and what do we know about medicine. And then I'll give a couple of examples, one eye-related, one non-eye-related, and then I'll get Fran to present some of the results from the lab, including some results from her PhD studies. So I often teach a fourth-year course in chemical engineering and medicine. And the very first day, this is what I say to them. Okay, so why are you in this course? You're engineers. Why are you interested in medicine? What does engineering have to do with medicine anyway? And when you look at engineering and the definitions of engineering, it typically involves the use of scientific discoveries and relating those to develop practical applications. So to create devices, structures, processes, materials, and systems that can be used to benefit people. And the one thing that you can't forget about engineers is we also like to generate income. So we always worry about how much it costs to make it versus how much we can sell it for. So we do a lot of studies of, okay, so does this actually make sense to make it? And in some cases, like a lot of the stuff that we do, the cost and the benefit is for the patient. So when you typically think about engineers, you think about bridges, you think about plants that make things, you think about cars, you might think about heat exchangers or polymers, but tends to be big processes to make big things, to make things that will benefit society. So what do engineers actually know about medicine? Well, I tell my students that engineers actually know a lot more about medicine than they think they do. In second year, we learn an awful lot about pumps, and really what's the heart? The heart's just a pump. So I can put an equation to the heart, which is what we like to do, and talk about the output. The blood vessels, well, they're really just tubes. So we can talk about flow in tubes, and we're really good at, again, figuring that out. The liver is really just a factory that produces proteins from raw materials. It also does waste disposal. So again, two things that we know an awful lot about. The kidneys, Dr. Margetts knows an awful lot about that. Filters to remove the waste at their very simplest form. The skin, just a protective barrier. The brain is really the control center. And then the eyes and the ears and the muscles. So you can see how all of the different types of engineering come together. And I'm really a chemical engineer, so I'm interested in chemical engineering applications in medicine. So one of the things that I always tell my engineering students is that if we were to create a pump that pumped enough blood to go around your body every day for 70, 80, 90, 100 years, you would be a very successful engineer. We can't make pumps that last that long. We can't make tubes that work as well. We can't make chemical reactors that work as well. So we can learn an awful lot from the way the body works and the way the body's engineered, and then try and replicate that in some of the devices that we try and make. So bioengineering is a relatively new sub-branch of engineering that takes the principles of biology, so chemical engineering, principles of chemistry, electrical engineering talks about taking electricity. Bioengineering really takes the principles of biology and marries those with the engineering kind of will to create a device or a product or something that benefits society. And you can think about all kinds of different things: medical, pharmaceutical, environmental, and fuels. The ones that I'm most interested in are the medical and pharmaceutical ones. And then tissue engineering is taking this just a little bit farther and actually using what we know about what the tissues look like and bringing that together with the biology and creating a brand new tissue. So tissue engineering is a bit of an old word. It was coined back in the late 90s, and now they talk about regenerative medicine, which is much broader. So that includes all of the new things like stem cells and creating scaffolds for materials. But that's really the kinds of stuff that we're interested in. How do we make materials? How do we make scaffolds? How do we make cells do what we want them to do? How do we bring all this together in some kind of an engineered form? And to do that, we use biomaterials. So biomaterials are defined as non-viable materials used in medical devices intended to interact with the biological system. So at the top left, you've got a hip joint. So you can see the ball and the socket. And then on the outside, it's coated so that the bone actually integrates within the system. On the top right, a stent. So that's used to open up the coronary arteries in the case of some kind of a vessel block. The bottom left, relatively easy, that's a hand of some sort. And the bottom right, one that's very close to my heart, an intraocular lens. So these are devices that are made of biomaterials that have been engineered to perform the biological function that they need to perform. So why do we need these things? Well, because I'm an engineer, we always talk about money. And we talk about the number of patients. When I write grants, I talk about the number of patients that the work that I do can help. And all of the people who write CIHR grants do exactly the same thing. So millions of North Americans every year suffer from end-stage organ and tissue failure at a cost of about $400 billion annually in the US. That translates to about 8 million surgical procedures. And treatment options include things like transplantation, so taking something from another patient or taking a part of the patient's own system and replacing it, reconstruction, and what I'm interested in, mechanical devices. So why is this important? Well, these numbers just show kind of how important it is. These are old numbers, 1998, but I think if you look at the percent unfulfilled, it should convince you that there are an awful lot of people out there who are waiting for potential treatments that can't have them, that they're just not available for them. Either the tissue's not available or they're not good candidates for the treatment. So transplantation, we still talk about this, there being a critical donor shortage. There's just not enough tissue to replace all of the hearts and lungs and livers and kidneys that we need to replace. So for example, there's something like 3,000 livers for 30,000 people in need, and the people that get them are obviously the people who are the best candidates. There's the potential for disease transmission, and just when we think we've got one under control, a new one comes out. So HIV, hepatitis, Creutzfeldt-Jakob syndrome. We used to think that the cornea, for example, was quite a safe thing to transplant. And then we learned that it contains prions, and that can translate, or that can transfer essentially Creutzfeldt-Jakob syndrome from one patient to another. So there's a couple of documented cases of that happening. Surgical reconstruction isn't always possible, and it sometimes can lead to complications. Sometimes manipulating the tissue can lead to things that you don't necessarily want. So not always an option. So then we go to mechanical devices and engineered systems. However, we're limited by the complexity of the human body. So typically when we try and engineer something, we take the most simple function of the system and we try and incorporate that into our device. We don't try and cover off all of the things that a kidney would do, for example. We look at, okay, so what do we need? What basic function do we need? And we try and get that. Do we incorporate living components? Do we incorporate non-living components? So there's a benefit to incorporating cells, but there's also a detriment to incorporating cells. And how do you balance that off? Materials, what materials do you use? So we use all kinds of different materials, and every time I talk to companies about using anything new, anything that's not already approved by the FDA or already out there in some device, they get a little shaky. They worry about the fact that the regulatory hurdles are going to be too huge, but there's lots of new materials out there, there's lots of new combinations of materials that could really solve a lot of our problems, but the people that take them from the lab to the patient, the companies have to be willing to spend the money to get through the FDA approvals. So this is where the engineer comes in, because we understand all about these things. We understand design, we understand materials. The biological side of us, those who have done biology understand how do you combine them with the drugs and the cells, and we can get better treatments as a result. So just to give you an example of simple biomaterials that are used on an annual basis, the first materials that were really widely implanted were intraocular lenses. And the story around that, the really interesting story around that is during the Second World War, there was a surgeon, a British surgeon, Dr. Harold Ridley, and he observed that when fighter pilots came in and they had pieces of the windscreen from their planes in their eye, they didn't have any kind of an acute or chronic reaction to it. So he thought, boy, we could probably use this in ocular applications, and that's where the first IOLs came in. They were hard, and they were really tough to implant, so the surgery was actually a lot more complicated than making the materials. The materials that we use now are much softer. And if you look down the list, there's huge numbers of materials that are used in medical applications every year. And a number of different polymers, a number of different metals, a number of different ceramics that have been approved for use in the body. So I'm most interested in polymers. My group does work mainly in polymers. And if you look at all of the polymers that have been used, you think, okay, this really isn't a polymer that I would think about using in the body. So silicone rubber, you might think about, well, bathtub caulking, right? A sealant maybe. But actually, silicone rubber is pretty widely used in catheters and tubing. Teflon, right away you think of that non-stick fry pan in your kitchen. And the story around that one's also really interesting. It was a scientist from DuPont and a surgeon happened to be going up a ski lift together at Aspen, and they were talking about the things that they did, and the chemist from DuPont was saying, well, I've come up with this new material that nothing sticks to, and you know, they had trouble actually getting it to stick down to anything, and the surgeon said, hey, I have an application for that. He was a cardiovascular surgeon, and he was interested in creating something that stuff didn't stick to. So Teflon's fairly widely used in vascular grafts and catheters. Dacron, again, when you think of Dacron by DuPont, you think about maybe carpet fibers. You might think about, you know, the coat that you're hopefully going to pull out soon that's waterproof and will keep you dry in the spring. But probably the most used material for vascular grafts. Polyurethanes. Probably don't think of polyurethanes all that often just because they're kind of in a lot of different things, but we don't think about them. Maybe insulation. You might think about, they're used, for example, widely in the aerospace industry for sound insulation, for insulation in planes. They're also used very widely in running shoes. So if you're interested in, you know, what the soles of your shoes are made of, they're probably made of polyurethane. They have really nice properties from that perspective. But again, they're used as catheters and pacemaker leads. The insulating properties of polyurethanes make them really interesting as pacemakers. And then hydrogels, and these are really the only materials that were actually engineered for use in the body. It was a scientist from Czechoslovakia, and he was interested in lenses, contact lenses, and he was looking for something soft and something that felt nice on the eye. And he developed the first hydrogels and the first hydrogel contact lenses. So really, those are the only materials that have actually been engineered for use in the body. All the other ones were engineered for some other application, and they talk about the hero surgeon said, oh, but I can use this in some patient. And I always tell the students that it's not really the hero surgeon, it's the hero patient, because they were the first one that stuck this stuff in. And the thing that you have to remember about polymers is, you know, they're long chain molecules, they're like proteins. So the thing about a molecule that's long is that you don't necessarily have to worry about a huge biological response. The body mounts a response, but it's so big, there's really nothing that they can do with it. So it tends to wall it off. It tends to create a barrier around it. So polymers are actually a pretty good solution. The problem is you have to purify them to the point of craziness. I mean, they have to be incredibly pure to put them in the body, because any little stuff that might leach out of them over time, that can be a problem. So all of these materials have lots in common. They weren't designed as biomaterials. There's no biological interaction. They were designed not to be biocompatible, but they were really designed for something else. And then they were optimized for biological applications by trial and error. So these are all the ones that the FDA has said, okay, these are okay. And now we're kind of getting to the stage where we're starting to develop materials based on the properties that we want them to have, and how do we get them to do what we want them to do. So I'm going to go through kind of a quick example of blood contacting materials, because these are really among the most developed biomaterials. So I'm sure that you guys have, know a little bit of heart anatomy, and you know about what happens when you get a blocked blood vessel in the heart. So you can get shrinking of the arteries to the point where, the patient might experience angina, they might have some pain. It's hard for the blood to go through. They might have problems when they exert themselves. They might have clots that are forming on the inside. They might have plaques, so calcified plaques that are forming on the inside of the vessel. And then they might have a completely blocked vessel, which leads to, in the heart, a heart attack, which in the kidney leads to kidney failure. So this would be an example of a plaque in one of the vessels in the heart. And this would be an example of a clot that's formed in the heart tissue. So treatment options for this, well, lifestyle changes. I mean, the first thing you do when you've got a patient that has problems with their heart is you try and get them to change their lifestyle. You get them to stop smoking, you get them to start exercising, you get them to change their diet. You might give them some drugs. If it's really bad, then you might go in and try and open up the blocked vessels, and stents are very much biomaterials. They're like little, almost like little springs, tiny little springs that you would put into a vessel. Coronary bypass surgery, so you might be able to use the saphenous vein or the mammary artery. We can't really use artificial tubes, because the tubes are such that the diameter of the inside of the tube, what happens when you put it in is you get a biological response, and that biological response shrinks the diameter of the tube down to the point where the flow doesn't go through anymore. So that's a huge opportunity for people who are trying to develop engineered solutions. And then ultimately, the holy grail of this whole biological field is to develop a total artificial heart. So to be able to implant something into a person that is either made of cells or made of materials, you put it in and it does its function, and you don't have to worry about a heart being available. So biology is really critical to what happens in all of this, and understanding the biology is absolutely essential to being able to move forward with developing better materials. So if you're looking to develop a material that interacts with blood, you have to know what happens when the material interacts with blood. So the first thing that happens when you put anything in contact with a blood-containing solution or a protein-containing solution is the protein sticks down. And this happens in a matter of milliseconds. And the proteins on the surface either denature or don't denature, and then that leads to all of the subsequent interactions. So that's known as the first and fate-determining step in these materials. Following closely behind the proteins are platelets. So these are cells, they recognize the epitopes on the proteins, they come in, they stick down, they have some kind of reaction or they have no reaction. So there's two places where we can start to control things. And then we end up with a response. So then the third thing that happens is you've got fibrinogen, a protein from the plasma that comes down again, that lands on this surface, and it catalyzes the formation of thrombin, which leads to the formation of fibrin. Essentially, that's a polymer on itself, brings all these platelets together, creates what would be shown on the bottom right-hand corner, a clot. And this happens with the material. This happens as a result of the body trying to protect itself, and it leads to essentially the blockage of a blood vessel. It leads to a blood vessel closing off. If we have an artificial material, it leads to the material having a diameter that's much less than what it did originally. So one thing that's been very successful is to develop endovascular stents in order to open up blood vessels that have been blocked. So what you do is you go in with a balloon, you blow it up. Around that balloon is often a stent that leaves it open. When you deflate the balloon, you pull out the balloon, the stent remains in place, and it forces the blood vessel to stay open. So we've got a material in there. We know that the response to that material is going to be all of the same stuff that I just talked about. So how do you control that response so the blood vessel stays open so that you don't get clots forming, so that you don't get clots breaking away? So the stents are, from the engineering perspective, they're shape memory alloys, which means that they open up and they stay open, so they don't spring back. They open up with the balloon, they stay open. Neat property of the materials. And then often they're coated. There was some a while ago that were coated with anti-clotting agents. There were some problems with those. But they've got lots of open area as well to help with this clotting problem. So again, you go in, you leave the stent in place, you pull the balloon out, the stent stays in place, and it holds the vessel open. Not quite as nicely as what's shown on the bottom right-hand side, but in theory, that's what should happen. So before, you would have a vessel that's blocked, that has lots of plaques, that has lots of problems. And after, you would have a nice open patent vessel that the blood can flow through relatively easily. So taking this a step further, what happens when you just can't save that vessel? You actually have to go in and replace it. Well, your options are bypass. So you go in, you replace the artery with some other artery or some other vein. You bypass the space that's been blocked. And what would be really nice is to be able to go to the shelf and take off a tube and say, well, we want to be able to do this with a tube. So vascular grafts, and there are some that are commercially available, are essentially pipes that serve no biological function. They're just a pipe. They're just a place for the blood to flow. But the problem is they're subject to thrombosis on their own. So the blood clot can form on the surface. And as a result of that, these almost invariably become blocked. So there's been a lot of research over a long period of time to try and figure out how do we stop these clots from forming? How do we move forward with this? So the result of that clot, quite dramatically shown here on a heart valve, is shown on the right-hand side. That heart valve doesn't function anymore. It doesn't open, it doesn't close, and it leads to quite a negative effect, obviously. So the challenge for the engineer is to develop new devices that simulate the tissue properties, that have some kind of a biological component to them to take away the adverse biological response. So we can make materials no problem with the right mechanical properties, with the right physical properties that perform the function. But what we haven't managed to do is to be able to control the biology, to understand the biology and to be able to take advantage of it or exploit it and use it to develop new and better materials. So what we want to do is develop materials that become integrated with the surrounding tissue and that have some kind of a symbiotic relationship as opposed to the two things fighting with each other. So shifting gears completely, I'm going to talk about the area that I'm most interested in, that's in the eye. So there's a huge need and a huge opportunity, and we're one of the few research groups in the world that covers off kind of ocular biomaterials from the front of the eye right through to the back of the eye. So with the aging population, eye disease is becoming a huge burden to society. A statistic that I really like to quote in my grants because it's quite telling is that there are actually more Canadians that suffer from vision disorders than who suffer from breast cancer, prostate cancer, Alzheimer's disease, and Parkinson's disease combined. So even though we're kind of a small group of scientists working in this area. We're actually looking to help a large number of people. With the aging population, the incidence is increasing, and also there's an increasing incidence of health problems related to our lifestyle, our diet. So diabetes, for example, leads to all kinds of problems in the eye. So suddenly we've got a whole aged population that are having eye problems. They're suffering from glaucoma and age-related macular degeneration, and Fran's going to go through a bit of that later. But we've also got a younger cohort of patients in their 30s, 40s, who are suffering from the complications of diabetes and for whom there are really no treatments. So we're starting to understand the biology, and that's the first key component is, okay, so what's happening biologically? Companies are developing drugs to help treat these diseases. But the big challenge is, how do we get these drugs to the target tissue? So we developed a research network around coming up with ophthalmic therapies that could be used to treat patients using materials as the basis for this. So when we look at kind of statistics, we have more than 600,000 Canadians who identify themselves as visually impaired. And that's self-identification. So you might have a grandmother who has age-related macular degeneration, for example. I know I do. And probably until 4 or 5 years ago, she would not have identified herself as having vision problems. She's too proud. She just wouldn't say that, you know what, I'm blind. She would say, oh yeah, I can't see and I've got some problems. But so this is self-identification. And with an aging population, we're seeing an increased incidence of these: AMD, cataract, glaucoma. These are the big three, and these are the big three that contribute. And these have effects both on the person in terms of their ability to see and cope with society, but also on their well-being and their way of life. So people with vision disorders are admitted to nursing homes on average 3 years earlier. They suffer from depression at a rate that's 3 times higher. They fall twice as often, and they suffer from greater damage. And the rate of death is twice that of the visually competent population. So it's more than an inconvenience. The cost of health care is estimated at $6,000 per year for a blind person and about $4,000 per year for a non-blind person. There should have been a graph there, but anyway, it didn't show up. So what's the challenge? What are the big challenges? Well, a simple challenge, and one that all of you guys might relate to, is contact lenses. Lots of people wear contact lenses. Lots of people choose not to wear contact lenses because they're probably not that comfortable, particularly at the end of the day. So you might have trouble reading with them. You might at the end of the day feel like your eyes are gritty and uncomfortable. So this isn't one that you go, okay, so this is something that is really negatively affecting the population. This is kind of a choice. But it's a choice that wouldn't it be nice to be able to make. Something that's less of a choice is intraocular lenses. So patients in their 50s, 60s, 70s develop cataracts. The statistics say that cataracts are inevitable. They're an inevitable consequence of aging. So if you live long enough, you will develop cataracts. Absolutely. It's just changes in the lens of the eye. So the lens located kind of in the center, I'll try and highlight it here. So that's the lens right there. Changes in the lens of the eye that lead to your eye not being able to focus in the same way, leads to fuzzy images, leads to double vision and that kind of thing. Simple surgery, you go in, you take out the diseased lens, you replace it with an intraocular lens. 15 minutes, you're in and out. You're awake the whole time. The doctor makes a huge amount of money for doing this, so if you're thinking of going into ophthalmology, that would be a really good place to go because there's lots of need and there's good money in doing that. The problem is about 30% of these lenses develop secondary cataracts. So as a result of the cells that are left behind, you develop secondary cataracts. So wouldn't it be nice to go in and say, I have a 1% chance of developing a complication as opposed to a 30% chance of developing a complication. And if you're a pediatric patient, because your body heals so well, you have literally a 100% chance of developing a complication. But the greatest unmet need in ophthalmology is the ability to deliver drugs. So we put a drop on the eye, we lose right away 95% of it. So only about 5% of that actually stays on the eye. And of that, if we're treating a disease at the back of the eye is an enclosed system, almost none of that drop gets back there. So drops, effective, patients are okay with them. Lots of patients don't like putting drops in their eye, but they're okay with them. They're just not the best thing. Injections, recently, within the last 5 or 7 years, we've developed protocols. We allow injections into the back of the eye, so the proverbial needle in the eye, literally. They happen once a month. They're invasive. They're costly, right? It's an ophthalmologist's time. I've been told by my ophthalmologist colleagues that patients are literally sitting up, lined up against the wall, and she just goes down the line and sticks the needle in their eye and then comes back and makes sure that everything's okay, make sure that there's been nothing bad happen as a result. And this happens once a month. So you come back once a month and you have your injection into the eye. The problem is, in about 3% of these patients, there's serious complications. So if you're having this done every month and you do the 3% math and you figure out what the chance of you having a complication over what period of time, you can figure out that over 3 years, you're pretty likely to have a complication. And obviously then they don't allow this to happen for more than a couple of years, and that's why it's limited very much to the aged population. So I'll talk about contact lenses a little bit because my lab does some work in contact lenses. There's 100 million contact lens wearers worldwide. It's about 1% of the population, but it's only 4% of the 2.4 billion people who wear glasses. So in other words, many, many more people are choosing not to wear contact lenses, they're choosing to wear glasses. And there are 3 types of contact lenses commonly used. There are conventional hydrogels, so those are the ones that were developed back in the 60s by the Czechoslovakian Otto Wischerli. There are rigid gas permeable lenses, so these are hard lenses, but they allow the eye to breathe. And then back in the late 90s, silicone hydrogels were introduced onto the market, and these were thought to revolutionize the whole contact lens field. So these silicone hydrogel lenses overcame a lot of the problems that were associated with conventional materials. The material that was developed in the 60s is called polyhydroxyethyl methacrylate. It's a nice soft material. It fills up with water, spongy when you feel it. I should have brought one for you guys to pass around. It's easy to manufacture. The contact lens manufacturers love it. It's cheap, good comfort, and it wets well on the eye. But the problem is the oxygen transmissibility is absolutely awful. The oxygen is transported through the water, so the more water you have in this lens, the more oxygen you get on the eye, but it's not enough to make sure that the eye is safe. So what happens is that you actually get the eye trying to save itself, and how it tries to save itself is by growing blood vessels into the cornea. So patients who wear their lenses routinely overnight, who wear them for extended periods of time, suffer from this complication. So silicone hydrogels, when they came out in the mid-90s, these were going to overcome all of the problems with contact lenses. They have great oxygen permeability. You can wear them overnight. In some cases, you can wear them continuously for up to 30 days. The problem is the silicone, which is what allows the oxygen to go through, can stick to the cornea. So a couple of companies, both CibaVision and Bausch & Lomb, came up with methods of manufacturing contact lenses so that they didn't stick to the cornea. And they still allowed all these great things to happen as a result. So the problem with silicone is that it wets poorly. So you can imagine it being like your windshield on a day when it's kind of grimy outside and you've got this layer of grime on your cornea. You can't really see through it. Because they're more hydrophobic materials, they cause increased lipid absorption. So we used to worry about protein, now we worry about lipid from the tears. And that reduces the in-eye comfort. So suddenly you've got nice soft materials but cause complications in the eye. These harder materials that are better for the health of the eye but that are uncomfortable and that lead to other complications. So then the companies and researchers have had to come up with a way of improving the surface of these materials so that they perform the function that they need to perform while being comfortable when they're in the eye. So I'll skip this one because I think I'm getting too much into the material science of it all. In my lab, we've been interested in hyaluronic acid as a wetting agent. So hyaluronic acid, known to work in the eye, known to be in the eye, natural polysaccharide, actually most known to be in the knee joints, but also it has great wetting properties. It binds water like crazy, and so we were interested in whether it could be used as a wetting agent in contact lens applications. So I had a PhD student who did a whole bunch of different studies looking at both model conventional materials, so just hyaluronic acid or HEMA materials, and then silicone-based materials, and trying to incorporate the hyaluronic acid in a way that the companies would be interested in incorporating it. So in other words, it all has to be done in one pot. We can't have 3 or 4 different steps because that increases the cost of the contact lenses and the patients just won't buy it. So one of the first things you look at is okay, so how much water does it take up? Because the amount of water that it takes up is directly related to the comfort. And we found that when we incorporated different amounts of hyaluronic acid into the material, we saw an increase in the amount of water that it took up. So the presence of the hyaluronic acid led to increased water. On the surface, we found that it wet better. So the water contact angle, essentially if you were to wash your car and then wax it, you get the water beading on the surface. That's what happens on silicone hydrogel materials. We want the water to spread out. We want the water to smooth out quite evenly over the surface. And so again, we're interested in what happens when we incorporate hyaluronic acid into these materials. And if you look on the graph on the left, you'll see that we get contact angles that are, well, certainly not what you would get with just a HEMA material, which is more like 30 degrees. We get contact angles that are more in the 40 and 50 degrees, so more wetting as compared to a control silicone, which is more like 100 degrees. And then we were interested in what happens with these things with protein. So protein sticking down from the tears can cause your eyes to feel gritty, leads to end-of-day discomfort. So we were interested in whether the hyaluronic acid actually did anything from that perspective. And for sure, we found that when we didn't have hyaluronic acid in the material, we found that there was decreased protein absorption relative to controls. So if you look at the graph on the top left, comparing each of the bars, so the no methacrylic acid, so the dark blue bars, when we added the hyaluronic acid, there was a decrease. And then methacrylic acid is added commonly to contact lenses to increase the water uptake. So we were looking at, again, decreased protein absorption by about a factor of 2. So we decreased the protein absorption in conventional materials. And when we did it with silicone materials, our decrease in protein absorption was more like 9 or 10-fold. So we had a significantly lower amount of protein that was associated with our materials. And we didn't need very much HA, which is fortunate because it's really hard to put the HA into the materials. You don't need very much, but you get a fairly significant decrease in the amount of lysozyme associated with the materials. And I think this is probably the most dramatic result from these studies, was because when the protein sticks down, where you have the problem isn't that it's there, it's when it denatures. So when it's on your surface and it's denatured, it leads to much more negative effects. So what we found was that if we don't have the hyaluronic acid there, we get more protein, and that protein by and large is less active, so it's being denatured. But if we have the hyaluronic acid, we not only have less protein, but that protein is much more active. And what we found is that active protein leads to less adverse effects. So I think this is where I was passing to you, Fran, right? Talking about drug delivery. Okay, so Fran's going to talk to you about drug delivery and what my lab does there. But if you want to stop, and I can answer questions for you now, or we can wait until the end, whichever you prefer.